afternoon. Welcome to another Accreditation TV episode video. We're glad to have you here joining us today, and always glad to have our subject matter experts. Monica is like 2 for 2 now, 2 in a row. It's been a while now. She's on a streak. Try to keep that going. It's good to see you, Monica. Thank you for coming and sharing your wisdom. Obviously, my name is Steve Sponbrook. I'm with MSL Healthcare Partners, and we've got Russ Harbaugh, who's, of course, all three of us are with MSL. Russ has wound down his career and is now working with us almost exclusively now, working a lot. And we're glad to have Russ. He brings a wealth of knowledge to the organization. And so we're excited to have him here as well. Today, we're going to talk a little bit about personal protective equipment, particularly surgical attire. But before we get there, because I always forget to do this, I want to remind everybody, if you click on the 3 little dots at the bottom of the screen on the right-hand side, you'll get a little pop-up that says Q&A. If you open that window, you can interact with us and ask questions. If you put it in the chat, we won't see it till after this is done. Unfortunately, it's just kind of how the Zoom webinar works. But regardless, we'll be happy to do our best, and we'll do our best to answer your questions afterwards. So that, and the folks that if you're part of our Ready Now Connect community and you need your CEUs, let us know. We can get you on that too. And if you're not part of the Connect community and you want to be, let me know. We'll be glad to have you and get you signed up. So with that, why don't we get started? Anything I forgot? I think I covered it for the first time maybe in a year and a month. Without waiting till the end. So let's talk a little bit. I'm going to start with Monica, ladies first, and ask you a little bit. First of all, is PPE surgical site attire, is that even an issue from a regulatory perspective at this point?
It is. You would think after all these years that it might go away and be resolved, but it remains one of the top opportunities for improvement. In a document that the Joint Commission produced earlier this year that's outlining clinical improvement opportunities, preventing healthcare acquired infections remains the number one opportunity for the clinical side, and one of the top 3 areas that impacts the healthcare acquired infections is improper use or lack of use of PPE, specifically surgical attire. So it does remain one of the top topics for us to focus on. And in practice, it is something that I see consistent noncompliance with.
So do you mind some simple examples of noncompliance with surgical PPE?
Oh, absolutely. Just about every aspect of surgical attire will exhibit evidence of noncompliance in nearly every hospital. It just remains such a prevalent issue. So it can be anything from staff and physicians leaving a mask dangling around their neck. Masks are single use. They need to be taken off immediately after you remove them. They cannot be left dangling around your neck. To wearing personal clothing into restricted areas and semi-restricted areas like jackets from home or carrying in backpacks. Those are non-compliance issues. To nails. Nails remains a number one problem. It is typically part of a surgical attire policy. So there's a wide variety of things. Jewelry is something I've seen on the rise. People wearing jewelry when they should not be in restricted and semi-restricted areas. Everything from exposed earrings to necklaces, exposed to excessive rings. Those things are typically addressed in a surgical attire policy and recommended to not be worn or have limited use in those areas. So there's a wide variety of things that can be seen as noncompliance. Essentially, look at your policy, pick a topic, and I bet if you walk through your surgical and procedural areas, you'll find an instance of noncompliance.
It's interesting. That's a real deja vu, because it seems like we're talking about nails. I'm assuming we're talking about fingernails here, but nails and jewelry 30 years ago.
Yeah,
maybe
exactly. That's why I said it seems like this ought to be resolved, but it's not.
It seemed like, well, maybe to me, it felt like we made some progress, and then we maybe have taken a few steps backwards. I remember Judine Bartley, rest her soul, but many people know her as the mother of infection prevention. She changed my life one day. I was wearing a tie, and she's like, "You need to take that off." And I'm like, "No, why? I'm supposed to wear a tie. This is, back in the dark ages." And she explained every time, you wash your hands, every time you reach over a counter, that tie is just sweeping all those bugs, right? And now and I was like, I had never in my life thought about that. So Russ, go ahead. I'm sorry.
A recent point that has received a lot of attention is head coverings, and whether you can wear disposable head coverings or bouffant head coverings or washable head coverings, reusable ones that are then covered by a bouffant. So, that has been a recent hot topic, and there has been some refreshed guidance from some of the leading organizations on what to do about that. So, you just have to rely on your infection preventionist and your QAPI program to work together to stay on top of what that evidence is and make sure you're compliant with it.
Yeah, and circle back to the QAPI, because I think that's the key to most of the problems that we have out there. Well, it should be anyway. So we were talking before we hit the live button, and Russ, you were talking about how there's different requirements for PPE based on the job that's being done. Do you want to touch on that a little bit?
Well, I think it's important. I want to touch basis on something that Monica was talking about too, on the findings.
Sure.
I just want to back up just a bit, and then I'll jump into that real quick. But the thing that I've seen the most, and the facility that I retired from, there was always issues of people who work in the OR suites. You would see them a couple of blocks down having lunch in their surgical attire, right? And then they would walk back and just go up and go into the operating rooms and, put on their protective gear and that type of thing. But they would have on the same scrubs as they had. Our hospital made a big major change over the years, and they went to gray scrubs away from the blue scrubs. All the people that worked in the operating rooms had to wear gray. And so gray scrubs, they couldn't even go outside for the Tuesday picnic or barbecue. They had to stay within the building. Somebody had to bring them the food, because they found that, it was just something that was lax, I guess, in a sense, because they were wearing that outside of the building, or they were dressing at home and coming in with their surgical attire on. So making that change, helped define that protection, that personal level of protection. And so something that I think is happening, probably a trend nationwide, where they're defining the different types of PPEs that they're wearing as well.
That makes perfect sense. The reason we're chuckling is just before you joined, Monica and I were chatting getting in the green room, and we're talking about how we used to joke about people going out into the butt hut, and for the young people watching the video, that's where we literally, believe it or not, yes, I am that old. We used to provide smoking facilities on campus for employees, and people would go out in their surgical PPE and go have cigarettes a couple of times a day, and they go right back into the OR. It's like, how is that possibly?
Yeah,
So
absolutely.
same sort of thing, right? Going to the cafeteria, going out to the food truck, whatever, so that's an interesting solution, is the changing the colors, and you bring kind of allows the whole organization to police that a little bit
Absolutely. So to the subject you were talking about, defining, I think, the differences in your surgical attire, versus your PPE, I think that's key. That's important as we talk about this. And I was mentioning to Steve, I said, I think it's important that people have a better understanding of some type of kind of like a risk assessment, that word we love to use all the time, right?
Yeah.
But risk assessing, what are we doing? So if you're an individual that works in the operating rooms, what's your role? What's your responsibility? And what's your level of protection? Because there's going to be different levels of protection for many different people in that operating room. We talked about, okay, are you a person that's in there setting up the room? what level of protection do you need? If you're a person that's in there, maybe you're scrubbing to assist. Or what if you're the person that's, handling the contaminated instruments, the tools, when the operation, is over? And then what if you're the person coming in non-clinical and you're cleaning up the room? There's so many different levels that needs to be taken into consideration as well, just for the fact that you're going to have different exposures, right? You look
Yeah.
at your anesthesiologist, you look at the individual doing suction, various things like that. What type of personal protective equipment do they need? So risking that, looking at that assessment as well. And then, you talk about the fact that what could you be exposed to? So blood, body fluids, mucus, different things like that. You have to kind of consider the position that you're in, the role that you play, and then assess what level of protection you're going to need. I think that's key. I think it's extremely important. I think operating rooms do a pretty good job of that, but I think it's not bad to have that reminder, of taking a look at what's going to happen, and then what areas of your body could be exposed: your hands, your nose, your mouth, your eyes, looking at those exposures as well and assessing the risk, making sure that you allow for personal protective equipment to protect you from that. You
Yeah, I
talked
mean,
a
we
little
tend
bit
to
about.
think of,
Yep. Go ahead.
go ahead. I was just saying, we tend to think of PPE as being the protection for the patient. And obviously that's critically important to us. And a lot of what the surveyors are looking for is that infection prevention for the patient component. But it really goes well beyond that. And you touched on it. And for the staff, it's about protecting them from whatever that patient may be exposing them to, even when they're long gone, minutes, hours, even days, sometimes gone.
And a good reference is the OSHA bloodborne pathogen standard, because it does require, the types and amount of PPE to be selected according to, the different types of exposures that you're going to see. And ARON also has those, and CDC has those regulations as well that help outline and define what level of protection that you need in the position that you're in as well.
Russ, I think it's a good time to point out that, people think surgical attire and they think operating room, but surgical attire and the use of PPE for the protection of the patient and yourself applies also to other procedural areas such as endoscopy, cardiac cath lab, interventional radiology. And each of those areas need to be covered by your policy. Organizations have the opportunity to define what is required based on the evidence and what the national organizations on infection prevention recommend, and those risk levels. So is it going to be all the same for surgical services and procedural areas, or are there going to be differences allowed based on the setting that you're in? There's pros and cons to each approach. The more variation you allow, the harder it is to enforce. But there are some pros in tailoring it to the setting a little bit as well.
Yeah. For the non-clinical, when we go in and do a mock survey, right, we just gown up. And, people think, well, that's all you got to do is just have to gown up to go into the OR, or like you said, in endo or C-section or wherever the case may be. I mean, we don't think of the level that's required to protect, And it's not just to protect us, it's there to protect the patient, and those are the things. And when we talk about hair coverings, right, it's not about us protecting our hair or protecting us. It's about protecting the environment and what happens, from contamination, and we talk about beards, mustaches, ponytails, hair that's sticking out, of the coverings. There's so many things to consider when you're walking in there and you're trying to create that infection prevention barrier and, help those patients as well. The other thing that that they've kind of talked a little bit about too is religious caps as well, and that's been called out in OSHA as well. So that those individuals that wear those, then there's guidelines for them as far as the cleaning and replacement and various things as well.
Mm-hmm. Mm-hmm.
So I guess the next question is, any resources available that you guys can think of that would help hospitals with this? I mean, it seems like we ought to be well past these problems now, that obviously we're not. So,
Well, from the clinical perspective, I would there are a few leading national organizations that you should look to for guidance. And in fact, the regulations, including the conditions of participation and Joint Commission, I'm sure DNB has it as well. They direct you to follow the evidence. What is recommended by the national organizations. Four of those that stand out are AORN, the Association of Operating Room Nurses. They were the first to come out of the box with guidelines and very specific direction for surgical attire specifically. And they've taken a lot of flack for that. SHEA is another one. The Society for Healthcare Epidemiology of America. That's another organization for infection prevention that does consider surgical attire. Interestingly enough, they consider surgical attire to be one of their unresolved issues. They still don't have consensus within their own society on how to address it, but they do emphasize at least appropriate gloving. Another organization is the American Society of Anesthesiology. They were really kind of like the second organization that really kind of jumped on really addressing specific things around surgical attire. So they give pretty specific guidance on their websites as well. And then there's the Surgical Society, the ASA. For surgeons, the Surgeon Society does provide guidance as well. And the physician organizations, they've kind of really pushed back on a lot of what the AORN said around what is required for surgical attire. And they've actually started putting some thought and resources into some research around it, including research on shedding. What sheds? Do head coverings really prevent shedding of skin? Or do specific types of materials prevent more shedding than others? So this issue isn't going away, and in fact, it seems to go through periods of gaining traction around what needs to be emphasized and what doesn't. Then, along with those four organizations, of course, I would direct you back to the Joint Commission Survey Process Guide, which is a guide whether you're looking at Joint Commission standards or the conditions of participation or following DNV. It is still a guide, but it's very simple. They don't give a lot of detail in that source for guidance. It really basically says, go to your leading organizations, follow the evidence, write your policies and procedures to reference those, and follow your policies and procedures. So I don't know, Russ, you have anything from the non-clinical side?
Well, I think you brought out some great points there, though, because you touched on all the bases. The one thing that keeps popping up in things that I've been reading, obviously, is OSHA. When you look at 29 CRF 1910, it's your bloodborne pathogens, and it talks about it. And then you have NIOSH that you'll see, and I think it just really falls back to your hazardous waste and materials handling, as we kind of talked a little bit about earlier. That's starting to become, there's a little more emphasis placed on that. And it really does fall back to the operating rooms and how they're handling that contaminated product and materials, in the operating rooms, how it's being stored, transported, handled, as well. So those things have to be looked at as well and should be written into your plans, and into your policy, that you should address that specifically on how those items are being handled. I think that's key. and then tying in even your water management plan. I'm going to tell you, your water management plan, part of the whole process, right? And also looking at, we're kind of, I'll get a little bit off subject here just for a second, but your wet locations, right? How is your operating rooms being protected, with your limb panels and various things like that. Those are things that all tie together as well as protecting the employees and protecting that patient in that room. It's kind of some of the things are my thoughts, I think.
Yeah, and Russ, you touched on CFR 1910 and having the bloodborne pathogen component, but it also has that whole other component of protection of employees across the organization, not related to infection prevention, which is either the hazardous energy, hazardous, your pinch points, all of those things that hazardous operations, I guess, where when it first came out, I want to say it was like in the early 90s, and we did all these PPE assessments because you had to assess every single job category for what are the hazards. And then you had to determine what PPE was appropriate for those jobs. And then you had to document all that. You had to train everybody on how to use it, and then you had to make it available. And it feels like that was probably the last time anybody thought about it. It was about, almost 30 years ago. And part of that's just because of the regulatory environment we live in is we don't, thankfully get a lot of visits from OSHA or Department of Labor. And, the folks, DMV, Joint Commission, no disrespect for any of those, they're not really focused as much on that part of CFR 1910 as they are the bloodborne pathogen part of it, and for good reason. But it's worth mentioning that is out there, and people, if I'm a safety quality person that's watching today, you might want to ask the person that's responsible for employee health if we've even got those kind of PPE assessments and any kind of documentation about that, and the policy procedure on the stuff like that. And so I know Monica mentioned, who the experts were, and, from a facilities perspective, we kind of lean into the Facility Guidelines Institute for, telling us how to, do certain things in certain environments based on what we call them. And I was thinking, as Monica was talking about what you do in various places within the building, it's not really what you call it, it's what you do in it that matters, right?
That's
You can call it, the bus stop, and if you're doing an invasive procedure in there, you better have surgical attire.
Yeah.
So,
Yeah.
any other thoughts you want to add, either one of you, about this topic?
One of the things that, and I don't know if I'm going to go off subject here, if that's okay, but one of the things that we talked about, you have your surgical attire, right? You wear your gowns, your protection, and we talked about hats, right? And our bouffants and our protection there. Talk about our eyes, making sure that we're protecting our eyes. And it's kind of a myth because some folks say, well, if you wear prescriptive glasses, you're okay. That's eye protection. But when you get into an operating room, it's not necessarily, because you want goggles, you might want a shield, and those types of things to protect, because you're going to get splashed. Mm-hmm. A lot of surgeons might wear, the glasses with the scopes on them and that type of stuff. But others that are working in that environment also need to protect themselves as well. And then we get into respiratory, is where, we're thinking, okay, we got a shield, but we might have to wear a mask, right? Or we might have to wear a respirator. So how are we protecting ourselves when we're in those operating rooms with those special features? It's not just about the hat or the gown or the gloves, it's about other protection as well. And I think, it's extremely important to understand that, because a mask in itself might not protect. You might need, depending on the patient and the procedure, you might need an N95. And, you might need something, a little more protection. N95, is that protection? Is that protection enough? So I think those are things, as we talk about personal protective equipment, fall into that as well.
Yeah. I had to chuckle during the pandemic when everybody's buying N95s and no one had ever been fit tested in them, and you'd see the gaps, and you're like, yeah, it's doing you a lot of good. But yeah, and that's the other part of that is making sure if you are using N95s that you've been fit tested and you know how to put it on and get the seal. Because if you need that kind of protection, you need to know how to use it properly. So, we got just about 5 minutes left. I just wanted to, talk a little bit about, what are some of the challenges that you're seeing related to, the mobile workforce, I guess, for lack of a better way of putting it. But, we got people that are kind of rotating through our facilities and facility and traveling nurses, try to travel in disciplines. It takes time to go through this training and make sure that people are competent and current in the use of this stuff. So how do you reconcile that? Make sure when you get that traveler that's in there and you want them to go to work right away, that they are competent.
Well, I guess, one thing I would say to that is by the standards focusing back to the national organizations, the national infection prevention organizations and so forth, at least those are consistent guidance across the nation, and it's not so specific from organization to organization. So if you can build your policies based on those national guidelines, there should be some consistency among the practitioners who are traveling among organizations, the travelers, the locum tenens physicians, the contracted people who are moving about, at least so there would be some consistency there. So if your policies, again, and your procedures are built on those national standards, and if you're going with the mainstream ones, that should help with the compliance. But again, it's boots on the ground, observing and giving that real-time feedback that I feel, from my experience, is going to make the biggest difference in helping your staff stay compliant. And understanding what your expectations are and making sure that in those very brief orientations that those contract and locums and so forth have to your organization, that you really do emphasize infection prevention, because it remains one of the top problems facing every healthcare organization out there. So, so quality folks out there I know you're constantly battling with the education departments, the medical staff departments, on making those orientations shorter, faster, briefer, less content. Well, there's some things that you really do just need to emphasize, and I will maintain that infection prevention and the standards supporting those are important enough to keep that detail in there as best you can. So,
Eventually, you whittle away enough of that log that it breaks in two.
yeah.
That's the reality, unfortunately. And then all of a sudden you're back to, okay, we gotta train all this stuff again. It's unfortunate, but true. But that was a good explanation. And it goes back to the QAPI program again, right? You want to measure and report that out so you find out, are we meeting our goals and objectives and compliant with our own policies, and where can we improve? And certainly if it's, the third leading cause of the number one problem that the Joint Commission's seeing in 2025, there's lots of room to improve, I think is a good way to frame it up. So any other thoughts? Russ, you look like you got one on your mind.
I'm sitting on the edge of my chair. Some of the most successful programs I've seen is where leadership takes an interest and involvement, and that's rounding and observing, and having, our secret shoppers, and taking notes and making sure that people are doing what they say they're going to do. If you're going to take the time to write a policy, if you're going to put procedures in place, making sure that people have a great understanding, a better understanding of it, and that they're doing what they say they're going to do. And we see this so often when we're out doing surveys that these are the things that sometimes get cited, is that people say they're going to do something, but they're not. And so like I said, the most successful that I see are people who do that. They report it out, like you said, in your safety, your patient safety meetings, in your daily huddles and various things like that. And it just brings to light that everybody is concerned or takes an interest and cares about that patient. And I've seen very successful programs due to that.
Starts with culture, which starts with leadership.
It-
Monica,
it
you
does.
have anything you want to add before we close it down?
Just for those new quality leaders out there, regulatory leaders out there, I'm just going to real quickly name off the 4 standards that you need to pay attention to, because I would be remiss if I didn't cite the standards,
I know.
being the geek that I am. So just pay attention to the COP 482.51, surgical services, 482.42, infection prevention. So those are the federal regs. And then Joint Commission, specifically IC 040101 EP3, and the National Performance Goal 050101 EP1 talks about the surgical attire and infection control activities. And then lastly, again, everything rolls to leadership. LD 130109 EP1, which specifically reads that leadership's responsible for policies and procedures to uphold the high standards for medical practice and patient care. So again, that's where this would roll up. If they see failures, it'll roll to leadership under this standard.
Awesome. Well, I'm glad you got your standards in there. And for the record, we got through this whole thing and I didn't mention aviation or the space. Wait, I guess, well, I didn't talk about it anyway, so I did bring it up. Well, thank you both. It's good to see you. And as always, the information is amazing. So appreciate your time. We appreciate you guys joining us. We look forward to having you on the next one. Again, if you need your CEUs, jump on over to the Ready Now community and we'll get you hooked up with that. And if you're not a member, let us know. We'll hook you up with that as well. So thanks again, and we will see you in 2 weeks.